is here yet, but we won't hold all this longer. So, so today we have two panelists. Unfortunately, at least we heard from one other panelist. She cannot come for today's session, and we didn't have any news from Madhav yet. So we will start with the two panelists that we have today. So we have Ilham from University of Toronto. She is expert on digital health, machine learning techniques. And we have Cherryl, and she is expert on quality health care and social programs for communities. So we have like two panelists that they have a different background, and we want to hear from both of you about a certain question that we have around early warning system. So thank you for being here today and for your time today. So we will start slowly. So I cannot see very well all the sitting. Okay. So the first question that we have on this panel is around all the implication of communities to ensure that we can have a better signal for example, any infectious disease outbreak. So the first question will be to Cherryl. What do you think about engaging and empowering communities to help on global disease surveillance?
Okay, thank you so much for that question and for the invitation to participate today. Can you hear me okay?
Yes.
Yeah. Okay. So just a bit of context. I'm the executive director at a community health center that is in Toronto. It is in the northwest part of Toronto, a community that is labeled as being with a high percentage of people that are described as vulnerable. So in living in low poverty situations, many people with precarious jobs, many people that are newcomers to Canada that may not have a good sense of our healthcare system and health and social service systems to help with their health and well-being. So when the COVID pandemic came upon us, we knew in the community, based on our history of the clients that we serve and their health conditions, their precarious health conditions, we knew that they would be a high infection rate in the community. So we, having a history of serving this community, we really very quickly mounted some advocacy efforts to ensure that our government will take a look at this community and ensure that there was equitable distribution of resources to address the pandemic, such as availability of COVID testing, availability of vaccines in this community, because we knew that there was just a high probability of infection. And unfortunately, when we advocated for the collection of data, social demographic data, what we learned was, yes, this community, again, had high rates of infection, and the populations that had the highest rates of infection were those racialized groups, those particularly the Black community, as well as people living in poverty. So there were predictors that indicated that this would happen, but unfortunately, there was a failure in really responding to this community very early in the pandemic. And I can speak about that a bit further in the conversation.
Thank you. So can you describe to us what was the main factor that led to this failure in in addressing the COVID-19 for the Black community in the Northwest?
So again, I think the lack of attention perhaps to the data. We knew when we looked at the maps of where the highest infection rates were, where the highest hospitalization and deaths due to COVID, when we looked at the map across the city of Toronto, that map really mirrored the social determinants of health barriers that people had. So lack of jobs, lack of good jobs, lack of affordable housing, lack of, and other things. High rates of people who were living in crowded housing situations. And we know that these are things that predisposes one to contracting transmissible diseases. These were also people that could not stay at home. They couldn't work from home because they had jobs that were essential, factory jobs. They were in close proximity. They were on transit. So the fact that the government did not act on this early to say, let's make sure that this community was first in line to having accessible testing and vaccination strategies was I think, a failure, because what ended up happening is we had to advocate very, very strongly in the media with our decision makers to bring vaccines and resources to the community. The early response was to direct us in the community providing services to screen people from certain countries, and for example from China, to screen them out of our services, which I think has some is problematic, and it's something that's also happening now. So again, when we think of lessons that were learned, those lessons were not learned.
Thank you so much. And as a follow-up question, and you pointed out the fact that people in the marginalized communities, they don't have this luxury to work from home. So they need to go and work outside. So sometimes they don't have time to go and do the testing, or they are afraid to do the testing because if it is positive, it's maybe 3 or 4 days or 1 week without any salary. So how like the community health center did address all those issues, and did also communicate those things properly to the whole community, that they are thinking that some communities, they are hotspots, and they don't know really the reasons for that, or they don't know how like because of all this poor communication.
All right. So again, members of the community, they know their circumstances. However, what is disappointing is that our systems do not respond to those dire circumstances that lead to poor health outcomes. In a community-based setting, healthcare setting, we are very we use community-led strategies. So we really engage with communities in any kind of service delivery model that we in any service delivery model. So what we did, one of the first things is that we recruited and hired what we call community ambassadors to help us spread the messaging in the community that we would launch vaccination and testing sites in their apartment buildings, for example, and in close to where they were. We knew that there were barriers for folks who did not have a job that would give them paid time off to get a test or a vaccine. So we made sure that we brought the services to close to home. We did not have appointment booking systems like some of our other like the public health units did, for example, because we knew that people might not even have access to the internet or have access to a phone to make an appointment. So we made sure that we had low barrier strategies to ensure that people got the care they deserved, where they deserved it, and when it was convenient for them. And again, we used a lot of in-person strategies. At the time, as you all know, as this conference even, much of our world became virtual. However, many of the people that we serve do not have the ability to access online learning opportunities. And, you know, it was also one of the other things that we had to really work against was the high rate of hesitancy in the community around even testing and vaccinations, again, based on historical mistreatment and discrimination within our systems. It wasn't really about lack of understanding of COVID and its impact, but it was really around some distrust of our system. So we had to work very hard to engage with our community and provide them with factual information and to dispel some of the misinformation that was out there, which there was so much, as we all know.
Thank you so much. And it's all about trust, because we saw historically that a lot of communities, we just want data from them or want like some specific thing, but it's all about building this trust to ensure that we are doing things also like in appropriate way. It's not just collecting data and showing some analysis that can be maybe wrongly interpreted, because we don't know all the other factors that are leading to some conclusions, and it's usually barriers or discrimination or stigmatization around some communities. And this maybe led us to another question, different question to Ilham. So what do you think about all these sources of data that come from communities, or how we can integrate those kind of data in modeling or in to build like a robust early warning system?
Great, thank you. So first of all, I would like to say hi to everyone who attended this this call. Thanks for the invitation. I'm very pleased to be here among you all experts and talk about the experience that I had so far on this hot topic, like very important topic. So just to give you a little context about where I'm coming from. So I'm a scientist and at Vector Institute, and also affiliated with the University of Toronto. What we do at Vector is to bridge the gap between the fast-moving AI and real-world needs, healthcare needs, and we try to move the high-quality AI from research labs into applications. And once we talk about AI, so we always have two objectives in mind. Is we would like to optimize the operationally compute intensive and expensive tasks, and also we want to be as good as humans and also do some of the work that are beyond humans' capacity. So think about, like, you know, in the healthcare context, and when someone goes to a clinician, for a clinician to come up with a decision or make diagnosis, they usually capture information from different channels. Like they look at the patient's history, they look at the blood tests, they look at like the images. So this is like, data comes from different layers, different modalities, and the clinician tries to put them all together to come up with a decision. But so what this implies is that, like, this is what AI needs to do, to capture data from different modality. And also, like, clinicians are able to look at the data inside the healthcare setting, during the patient's visit. But like, so it goes back to the question that you raised. So what's happening to the patient outside of the healthcare settings, right? So in their journey, and as also like Cherryl mentioned, not everyone goes to the doctor. So not all information about patients are captured. So there are some, we have the dots, but we should be able to connect the dots. So the reality is that these days we have access to many sources of data through social media, through wearables. We can get access to patients' genomics if requested. So so the data is digitized right now. So we do have access to large amounts of data, but the question is, how can we combine them all together? How can we put all these sources of information together? So for sure, there's no doubt that lots of valuable information outside of the healthcare settings, coming from community relations and everything, is available to us. But how are we gonna kind of combine them and learn from them? That's an open-ended question. Happy to provide further insight into that.
Thank you so much. My other question was about there are multiple, we can have several early warning systems, some of them based on text mining or social media, other based on more classical surveillance data. And we can also have other sources of data that comes from the communities. So how we can combine all those alerts to maybe have something more robust and more specific to some communities, and not just the general picture of the spread of infectious disease.
So this is a great question, and so it basically goes back to my former comments about, there are valuable source of information for patients' health in different modalities. And so if we look at each early, let's say that there are many early warning systems available to us, but if we dig into them and if we explore them, we might find that each of them has addressed narrowly defined tasks or defined data, right? So they are not all designed the same way. So one of them one early warning system might have used EMR data. The other one might have used data from social media. The other one might have used another source of data. So for sure, there's always, it would be an improvement if we could combine them all together. In AI, we call it, this expression of mixture of expert. If we look at each of them as an expert, so we can always combine them, and there are different ways of how they should be combined, from if you want to infuse the information at what stage. So again, so there are variations among different systems and the ways that they've been evaluated. So there's always a chance to combine them all together, but we have to be careful about, making sure what piece of information each provides to us and how they've been developed, and, the outcomes or the value that they provide to us might be different. So again, it goes back to, how we're gonna concatenate all this information and coming from different modalities. So did I address your question?
Oh yeah, definitely.
Missing?
Yeah.
Okay.
Yeah, definitely. So we also have yesterday this discussion about having open early warning systems, so we can go and play with the code or with the data, and maybe the community or scientific community or the community may make them robust, and there are already some platforms that the citizen can go and report, for example, the ticks population, and so we have like this discussion about how certain we like about the uncertainty of using those data in building like a robust early warning system, because like if we have a classical surveillance, we have like a good idea about like a very good type of data that we used to use in the past, and now we have all those other sources of data, starting from social media, open access data. So the bias maybe will be maybe large, and also the fact that not all the sources of data catch all the demographic or socio-demographic factors. So there are like a trade-off of using all kind of data, and we should like maybe way depending on the bias that those data is reporting, and so
this is exactly true. So basically, like, you know, in my research and in my work, so I work with different types of data. For example, we did one social media study to learn more about long COVID, and what we realized was, so we can get valuable information from social media, but the data is very biased, you know, because like we just extracted, like we worked with English tweets, Redis data that were written in English. So this is the first bias, like, you know, we limited ourselves, you know, to countries who are speaking English, or the users who prefer English over other languages. So that this is the first source of bias. And then the other was, not everyone have access to social media platform to talk about, you know, their experience. So the experiences. And then, you know, we extracted information. But the third question for us was like, what if we could have, you know, linked this data with electronic health records, so to get richer information, more somehow, like, you know, social media is good because you learn about also outside of the healthcare settings about patients, you know, self-report, but it's good to have some more robust, or like more accurate sources of information that comes from blood tests and those. And so then we can come up with a rigorous approach, you know. So like, you know, again, each of those could be an individual different early warning system, but just putting them all together gives us more information, or like more robust information than one.
Thank you so much. So I am going back to Cherryl, and I want to ask like a question that I have personally. It's about the gap between like the research that we are doing right now and the research based on like involving communities in the research. And we tend to have like, I was looking a little bit last week about like some scientific articles or some protocols that were done based on some heavily contribution from the community, and there are very few ones. And I can't understand that the research is going fast and all the researchers want to publish, and so. But I feel like we need a little bit to maybe have a reflection about also how we are doing our scientific work, and we need first in those specific questions to go to the communities and build trust, and maybe it will take couple of months or couple of years, but it's really important to have this trust between the researcher or the public health experts and the communities before starting doing something like very, very good. Do you have any comment about this?
Yes, absolutely. And again, the pandemic has taught us so much. And one of the first lessons we noted in the community was when the vaccines were first approved. One of the questions from the Black community was how many people of African descent were participated in the study to validate the efficacy of the vaccines. And those numbers were very low. Participation rate from in this case, maybe Afro-Americans. So, this raised questions within the community itself as to what are the barriers to participation? What are the barriers even to researchers that are funded to do the kinds of research with communities that are missing from where data is missing from our collection of research data. So I think this is a very important question for us to ask ourselves is how do we improve the participation in research of the members of the vulnerable population groups? So in our experience working with vulnerable population groups, Ilhan mentioned, the amount of data that we have, in our EMRs, our electronic medical record systems. We collect community health centers, that is, we have a history of collecting socio-demographic data. However, there's a lot of data missing around race and income. And we have to think, perhaps, people are distrustful as to why we're asking them to collect this data. And so, or why are you asking us, what our income is? So does it mean that we might be denied service? So, unfortunately, in populations that have a history of being mistreated, of being excluded, that's a very valid point that they make. So we have to do a lot of work in our communities to empower them and to sort of help them understand why we collect data. At our organization, our motto is we ask because we care. So we really we have to work with our staff. Right now we're working with some students from York University, and they're helpful in that they're hungry for the learning, and they're helping us to do some work with our communities to help understand where these gaps are so that we can fill them. Because I think we have to realize that here in Canada and I think globally there's a lack of good data that is representative of the diversity of people that we are all striving to serve and to ensure that they have equitable treatment and equitable access to care. And this is something that we have been working with, even here at Ontario Health. I'm in Ontario. We are working with our funders and decision makers. They've heard some of these things throughout the pandemic, and they are working on ensuring that hospitals and other healthcare organizations have the resources to help us to do this work better, because we have to learn that it's not only our genetics and other factors that impact our health and propensity for disease. It's about social determinants of health. How do we measure those things, and how do we ensure that we use that information in a way that's respectful and not re-stigmatizing our communities, as you said earlier? So I think researchers and communities have to work much more closely together, especially communities that have been historically excluded from some of our data that we have available to us.
Thank you so much. Do you have any comments how we can build all this trust? How, we have a lot of researchers here. How we can do a better thing that what we have been done historically around all those questions?
Well, I think right now there's a movement towards utilizing the EGAP framework. So that's equity, governance, access, and protection of data. So I think it's a matter of working with communities, again, especially those communities that have been disenfranchised, to help them understand the importance of collecting the data and the fact that the data will be utilized in a way to help them rather than continue to harm them. We have, unfortunately, have a history in our globally, we have a history of harming and re-stigmatizing folks. So even as we throughout the pandemic, you know, we saw what happened when people from certain parts of the world, you know, that for example, you know, where so from Wuhan, for example, were discriminated against, or people from South Africa when one of the Omicron, the variant was discovered. And now again, we saw what happened with monkeypox and what happened to people from Africa who were then, you know, sort of labeled, or to the LGBTQ community. So we have to be very careful in how we collect and utilize data that, and to do that, I think researchers have to maybe work more closely with communities, especially those more vulnerable community groups that have had these harms done to them as a result of information that we've gathered.
Thank you so much. I believe that the knowledge translation part is really important in this matter, to communicate better, like all the results that we have, all the analysis of the data, so in the way that there are no stigmatization, and they are in the way that they are very respectful things. So thank you so much. So I maybe will ask the people here if they have any question, any specific question. I know that maybe Jude wants to give some comments. So.
Thank you so much, Bushram, for this important session. And thank you so much, Cherryl and Dr. Ilham, for sharing your knowledge with us. We really appreciate it. My first question goes to Cherryl. You have done an amazing job putting in place community ambassadors, as you call it, that do not just stay at home. They were soldiers. They went out during COVID-19 when everybody was at home, taking care of people within the community, finding out what was happening within the community and bringing the data to the health center, the community, Black Creek Community Health Center, to see that you help the community. What I want to find out as we move towards creating earlier warning frameworks for our communities, how useful do you find the community ambassadors that you have put in place? And how often do the government come back to you to say, or policymakers come back to you to say, with this, what data are you collecting from the community? And how can we help you to solve the issues that you're identifying within the community? Do you work with policymakers to make meaning out of the data?
I think we've made some strides, and how, in our case, what we've been able to show tangibly was our vaccination efforts really moved the needle on vaccination rates in our community, where, for example, we started in while the city of Toronto was, you know, at a high rate, above 50% of vaccinations, this community was in the 30s, 38%. After we employed some of the community-based strategies, that number climbed to very close or almost surpassing the rest of the city. So I think that was a clear indication that the strategies that we were utilizing was working. And as a result of that, we were then able to secure additional resources to continue, you know, working as we work with the community ambassadors. And I think that some of the expectation that we will see, I mean, again, the vaccination rates, that was something very focused, and the effort was focused and it was easily measurable. However, what is not easily measurable and may take years for us to see an impact is a change in the health status of some of these individuals. So for example, people that are living in unstable housing, who do not have enough money for food, who do not have enough money for medications. These are things that we cannot, we may be able to start measuring them, because we realize that it has an impact on their health and on the healthcare system, because of course our system wants to save costs. So our overall goal is to save lives, number one, and to ensure that people have good care. But I think as a system, the government is interested in how do we save money. And we think our strategies will achieve that goal, in that it will keep people healthier in the community, and hence they may not have to go into a hospital or see doctors as frequently, which are high cost interventions. So our work is preventative, but it will take some time, because our starting point is not a very good place. Many people are not at a place. We are not as healthy in this community as people who are living in higher income situations, or from many other racial groups, for example. So I hope that answers your question.
It did, and I really want to thank you and the community ambassadors for what they've been doing in the community, touched close to things I care about and saving lives in the community. And talking about trust, I want to just turn my next question to Ilham to find out about, as the Vector Institute is a leading institute when it comes to artificial intelligence. It will be interesting as we move towards building these earlier warning frameworks, how they ensure that we should trust the models that our artificial intelligence experts within Canada are building to help solve problems within the community. And how do you ensure that the models are responsible, the AI solutions that you're building are responsible and take into account all voices, such that people are not left out of it?
This is a great question, and I'm very happy that you answered me this question. So I should have covered it in throughout the panel. So as we are moving toward building more and more AI models, so we are at the very high risk of, basically like that. Okay, so we have this AI model. What if the outcomes are biased? Because like we are training these models on biased data sets, right? In biased way, because we as human, the way that our data, observational data is captured is like their biases. And as Cherryl mentioned, like, they're not representative of the entire population. So for sure, like there has to be some mechanism in place to make sure that these models are fair and responsible. And this is exactly what we have started doing, is like building responsible AI principles around, any model. So basically under that, we have different mechanisms to evaluate the robustness of model, the fairness of the model, like, having, so basically like going beyond, accuracy and other measures, looking at fairness indicators, like how fair our model is across different cohorts, across different patient populations. So again, it could be across different lenses, and it requires having a team of experts to tell us, like, like Sherry, like tell us, okay, you should include this metric in your evaluation framework, and we will do that. And then we say, okay, so this is the outcome of the model, and are you happy with this? And it's a back and forth or an iterative approach. You come up with principles, and we are like, we have a team to put those principles into tools and actions. Yeah, I pause. I can go for for hours. We can discuss this for hours, but yeah, try to summarize.
Thank you so much. We have another question from the audience here.
Thank you so much. I thank you so much. Maybe just to appreciate your insightful presentations. You both did a great job. Maybe my first question will go to Cherryl. Appreciating that Cherryl uses the colonial methods basically to break down, access to health. I think we can learn from the experience of your community that healthcare is not a universal issue. It can be something that is culturally and contextually contingent. And for me, I personally find it quite interesting that you've had to put in a lot of advocacy efforts, in 2020, stretching to 2023, which is what you're still doing. Given that the Canadian government prides itself in taking a gender-based analysis plus, I think the government prides itself in taking a GBA plus approach towards programming and service delivery, which means then that part of the work that you're doing, you are meeting them halfway. You are actually advancing the efforts of GBA plus, which shouldn't be even difficult for them to respond to those data gaps that you have pointed out. What are the prospects, maybe if I can ask a question, what are the prospects of just using your advocacy efforts, basing them on their intersectional approach that they have explicitly committed to? Is it something that perhaps you and your team that you work with have considered to say, hey, we can actually use their own tools to advance our own cause of intersectionality and access to equitable health? I'm sorry for having such a long question, but my second question goes to Elan. I was just curious, I could pick up from your conversation, from your presentation, that there's actually this skepticism that exists between scientific research and perhaps a potential marriage with decolonial methods or decolonial approaches, or maybe we can call them community participatory methods, which basically enables, services to reach the people that are hardly or at the last people to be reached by such services. People talking about intersections of gender, intersections of immigration, intersections of income. What are the prospects of a marriage between scientific research and all these decolonial methods? And I ask this question, of course, because we want to say that, perhaps open data early warning systems are not safe because they may not be purely scientific and trusted. But at the same time, we are aware, we are alive to these gaps that exist, and we can see that, there are prospects of potential exploitation of such unconventional methods. Thank you.
Okay, so the first question went to me, and I have to say that, could you just maybe, you made a few comments beforehand, could you just ask the question, so for my memory again?
What are the prospects of your community, which is my community, using the GBA plus approach as an advocacy tool to get government to commit to its explicitly stated service delivery?
Wow. Great question. And this is something that I think there's a real disconnect between what our government, I think, promises to our communities and what is actually delivered. And unfortunately, what I see every day in our communities is that lack of really sort of looking at the intersectionalities, I guess, of what is happening within our communities and what really raises those barriers to care. So let me use an example, and I would turn it back to the researchers on this here today to think of, how can you help us, help the communities that do this work and that have the trust with our community members to get our governments to do a better job. So, for example, we know that within the time and now with the pandemic, even though the data shows that there was an equal number of, I guess, morbidity of COVID across the males and females, we know in this community, for example, we have a high number of single parent, female-led, mother-led families. And one of the concerns we have is what has happened to some of the children that have lost parents, single parents? What has happened to those children who have already sort of fallen way behind in their educational attainment because of the online learning and other things that have happened? So we again, this is a question of long COVID that I don't think anyone is well, maybe someone is posing that question, but there are so many layers that we can go into as to figure out how can we answer some of these questions and ensure that these children are taken care of, and that are there more of these children in child protection in the children's aid system, for example, and is there a disproportionate number post-COVID as pre-COVID? So, gender-based approaches, I think, in marginalized communities needs a little more, I think, sort of a deeper dive, I think, into many data sets. And until we do that, I don't think that even the government understands what the approaches should be that should be taken in our communities and where the investments should go. I hope I answered some of your question. I'm sure I didn't. But I just wanted to let you know, sort of some of what we see when it comes to these sort of disproportionate impacts in our community.
Thank you so much. Maybe your second question to Ilham, or do you catch the second question, Ilham?
It would be great if she can just repeat the question itself, and I can make sure that I understood it.
Thank you so much. The question was, what are the prospects of advancing the potential marriage between scientific research and community participatory methods or decolonial approaches?
Okay, great. So this is fantastic. So basically, like I in the former question, so I briefly mentioned about, so the thing is that, like, so I can answer this question through the lens of AI, the work that we do. Like, I see myself as a modeler, right? So I basically try to build models based on the data. So the way that, so looking at the early warning system, it's always our goal to make the models powerful. And the way that we can ensure that these models are powerful is just to evaluate them rigorously, And so when it comes to evaluation, what are the metrics that should be in that evaluation? And this is where, we all can meet and discuss together. Okay, so basically, like, then, we should have, individuals from this community. So they should come and say, so for us to find about the sources of, so we have to make some sort of troubleshooting and diagnosis and find about the sources of biases. And based on this source, we can come up with a metric to be included in our evaluation model, right? In our evaluation tool. So, so for example, Cherryl mentioned lots of sources of biases, right? So that are captured, inherent, there's some underlying, basically, they're hidden and not everybody knows about them, but people from the communities or executive directors or leaders, they are the ones who can bring up and be vocal about it and say, hey, this is it. These are like the sources or the metrics that should be included. And so the way it works is like, scientists should be very transparent about the work that they do, how they came up with this tool, like what was the procedure, hey, we use the data, this is our data, we built this model. And once we are transparent, then, the users, the knowledge users or other contributors, they can come up with their thoughts and solutions.
Thank you so much. For your answer, we have Professor Madhav with us. He just joined us. We are talking about early warning systems in general, and more specifically for some specific communities. So we maybe want to hear from you as well about how easy or how difficult we can combine different sources of data to have like a better signal for an early warning system, and how we can like put some specific data that is relevant to communities, so we can have like a better signal for some specific communities like the Black community or LGBT or other vulnerable communities. So we want to hear from you.
Yeah, thank you so much. And I'm very sorry, I was a little late. I want to start by just thanking the organizers. Jude, in fact, was very kind to invite me. Thank you very much. So let me give you my short answer. I quite don't know how the structure is set up for the meeting since I was late. But I want to at least tell you how we have interacted with our community here in Commonwealth of Virginia in the US during this pandemic. And hopefully that gives you folks some sense. But our group has been supporting our state. We've been the lead modeling group for our state and have been supporting them through our models throughout the pandemic. We work very closely with various departments, including the Department of Health, Department of Emergency Management and such. But we've also worked at the same time with the CDC and the DoD and NIH to provide support. We participate in the Forecasting Hub and the Scenario Modeling Hub, and many others on the call might have heard of this and might also be participating. So to the question of participatory surveillance in some ways, or getting early warning systems, at the start of this pandemic, we had very little data to work with, but we were lucky to get data from Google in terms of travel patterns, which was very helpful for us. Certainly, we didn't have any genomic data early on, but our partnership with our state did help us in the later part of the pandemic to get that information. What we've done is, in the last few months, we're trying to set up a multi-scale architecture to try and pick up various data sources that can advance this, from wastewater signals to genomic sampling that you do by testing individuals. But I think beyond just information that is largely biological in nature, syndromic information, and also data about from social media, which I think is important, and mobility data. I think you need multiple signals to combine them. And I think one of the earlier speakers, Elham, I think talked about use of AI techniques. This is one of the places where you can combine this in a very fruitful manner. So maybe I'll keep it short because I quite don't know how much time was allocated for each panelist, and I can of course take more questions.
Thank you so much. We maybe continue with the audience for some question. You had a question for earlier? No? No, oh, you are fine. Okay. Any other question from the audience? No? Okay. So we were talking a little bit about the fact that right now we have many early warning systems, and every warning system can give us a signal about specific things. So we were thinking that maybe having an open source development of early warning system can improve the surveillance and give us better results. So what do you think about this?
Is the question for me?
Yes.
Okay. So first of all, I think it's a great idea to try and bring various data sources together. One of the challenges, of course, has been sharing of this data. There are challenges in terms of privacy. I worked a lot early on during the contact tracing apps that were useful, but there are challenges in terms of rules and procedures and protocols that are put in place in terms of sharing. And I found that to be a challenge within even our state, where it's often not easy to get access to the data in a timely manner, not because people do not want to share it, but the procedures are not in place. And I can imagine the kinds of challenges we might face when we try and share data across states inside the US, but certainly internationally. But nevertheless, there have been success stories as well. The pandemic was good in some ways. I think the data that I talked about in terms of mobility that was made available to us through Google, and now SafeGraph makes such a data set available for at least large parts of US, is a great example of how data sharing can be done. Contact tracing apps have the potential to produce data sets that actually can be shared in a privacy-preserving manner if we decide to use it effectively. And genomic data, we just were part of our meeting where CDC has set up a network of pathogen centers of excellence. I was at a meeting there. And the goal of those centers is to collect, analyze, and make available genomic data sets, not for this pandemic style events, but other infectious diseases as well, through using a multi-scale surveillance systems. And I think that is another example of program that has been put together in the US at least, where sharing is possible. But I actually think that the goal to have such a sharing mechanism in place across countries is a very, very laudable one. We all know the challenges. We stand on our side ready to share anything that we can get access to and we sort of manage. But I think such an endeavor would really be greatly helpful in the future.
Thank you so much. And we were talking earlier about the fact that the early warning system is very complex and need data, need understanding of the disease, but need also resources from the government and from the funding agencies to at least maybe have like some willingness to do better than what have been done in the past. So I know both Cherryl and other speakers in the morning talk about resources, how resources is important to really do something good and not just cutting resources like will not solve any problem around infectious disease surveillance. Do you have any comment about this? So it's for both of you.
Cherryl, you want to go first? I have been speaking. Yeah, please.
I think I answered some of that in that, I mean, we continue to have to, be resourced to do this work, not only here in Canada, well, I would say even in Toronto and Ontario. One of our biggest barriers is data sharing. It's so, and we talk about patient-centered care a lot, but as a patient or a receiver of the service, when my data is not available to the continuum of care providers, is very challenging, and especially for vulnerable communities, community members who may not, speak English as their first language or have other barriers. It's very limiting. So I do think more investment. The right investments have to be made in our data infrastructure systems to help link data across not only healthcare in this case, perhaps, but across health and social services systems.
I agree with you, Cherryl. First of all, I would like to echo what she said, which is that we need these investments. And John is online, and he's heard my phrase before, where I've said that people seem to forget about these events after a few years. And so people start funding, and when events don't happen, there is a certain sense of complacency and belief that we don't need it. And so that the funding gets cut because it's viewed as a solved problem. But we have seen this during this pandemic that things that were stalled have come back to haunt us in terms of lack of funding. So I think it is important. I also acknowledge the challenges that the funding agencies have. Everybody demands these funds. So to do this effectively does require a national dialogue and perhaps an international dialogue. And I think there are potentially places where funding could be more efficiently used. I'm sure there are multiple projects that are trying to do the same thing, and we as a community might be able to better address some of the inefficiencies that we have. It's part of doing science to some extent where we repeat things, but maybe when funding situation is tight, which it will be in over years for this topic, I think one needs to be thoughtful about it. But having said that, I think hopefully we won't forget this problem, and that we'll come back and continue funding this kind of effort, even if we don't see large-scale outbreaks in these places.
Thank you so much. I saw one question in the chat. Usman, do you want to unmute yourself and ask a question, or you want me to read the question? So I can read the question. Yeah, go ahead.
Yes. Can you hear me?
Yes.
Yes. So I'm talking about the complexities in Africa and other parts of the world, especially as it regards to collection of data and building it into your model. For example, the issue of vaccination, it's quite a big issue in Africa that people don't really subscribe to it, especially in Nigeria where I am. I was with the government at some point where it was made mandatory that someone has to show his or her vaccine card for them to assist their offices before people started taking the vaccine. And same thing with the use of other non-preventive measures such as face masks and the rest of them. So the question is, because infectious diseases now can easily be spread globally, I think it's important to be integrating those kinds of dynamics in other parts of the world into your model, rather than just considering dynamics that are specific to the West and other parts of the world. Thank you.
Thank you so much for your comment. Any comments from the panelists?
Yeah, Usman, I think your point is well taken, right? That addressing these kinds of situations is not just an epidemiological issue, but a social issue. In fact, if we have learned one thing during this pandemic, I would say that after the first round, much of the problems emanated from the fact that we had social problems in the system, the sense of misinformation, conspiracy, lack of belief, lack of trust, economic challenges, fatigue that set in. All of it contributed to this, not just the event itself. We could have all stayed home for a couple of months and perhaps stall this, but that was not going to be. So, and the point about misinformation is not just restricted to an African country. This seems to have become a problem worldwide. Strangely enough, I would have never thought growing up that vaccines would be viewed with this level of circumspect, but for some reason this has happened. In fact, I feel that oftentimes low and middle income countries seem to understand the value of vaccines reasonably well, because they have seen infectious diseases going through the countries over and over again. So I acknowledge your problem, and I think it has to be solved by trying to make sure that people understand that vaccines really save lives. And maybe there are side effects for some vaccines, but I think as a scientific organization, the folks have done really a remarkable job in making sure that we know what the problems are and the numbers are really small in this. So transparency does help, and it has always helped.
And Osman, I would like to add too that I will echo as well what was just said. But again, this problem is not only limited to Africa. We saw a lot of this as well play out in the community that we serve. And in fact, I think one of the things we have to also question is, some of the decisions that were made around, some of the lockdowns and schooling really disproportionately impacts certain communities, and not whether it's communities that have a high vaccine hesitancy, as we framed it here, or just the fact that, marginalized communities, the masking mandates and in our community, for example, I'll tell a story in that Black men that wore masks were disproportionately stopped by police in our community. So, we always have to think of the impact of the decisions that are made and how they will affect different communities. And I think these are lessons that we can learn for the next pandemic. How can we, sort of, as we make a decision or a directive for how society should function, what are the impacts on certain groups, population groups? And there's quite a lot of learnings there. So thank you for your comment.
Thank you so much, Cherryl. Thank you, Madhav, for your comments. And we might need also to think about equity, a global equity around like vaccine, around treatments, around everything, because like we mainly focus on disease when it become endemic in the so-called the global north, but we don't focus on the disease when it's in the so-called the global south. So maybe we need like to see a bigger picture of all the data gathering and everything around the early warning system. So okay, so do you have any question in the audience or the Zoom, people on Zoom? Yes.
Thank you so much. I have a question for Cherryl and one for Madhav. Thank you so much for accepting to do this, and thank you for the great work that you have been doing since the pandemic and continue to inform policies and working towards the LF warning framework that you are building. I will start with you. As we work on building these AI automated systems, early warning systems, how do we ensure that they do not end up, Cherryl talk about how some of this, when we are putting in place measures, they may disproportionately affect people from marginalized communities. One other aspect is automation and AI taking all the jobs. What are we putting in place to ensure that we protect, as we use these systems, that will be very helpful. At the same time, we do not end up in a situation where people from marginalized communities are without jobs, and then they end up in a situation where police will end up again arresting them, because if you're an idle mind, you become a devil workshop and you may do things that may not be allowed or loiter around and be arrested. So how do we ensure that we prevent that? Strike a balance.
Okay, I wish if I had a crystal ball, that would be one of the questions I'd like to answer, because it's a reality. We are now living in a time where, as a result of the pandemic, of supply chain issues, people are, prices have gone up, and again, the most vulnerable are the most affected. So fast forward to people losing more jobs, not having a livelihood, we could be in another crisis situation. So I do think as we, we utilize or build tools, I guess, we need to, at the same time, create capacity building within these communities to create, sort of better skills, different kinds of skills. And, not everyone in the community that we serve, we do a lot of programs to increase educational attainment and, sort of build skills amongst the population that we serve. And we have to continue doing that. And if the research can to point us into, predicting what tools are most needed in the future, I think that would be a great thing to have in our arsenal of sort of capacity building initiatives that we can roll out. But we definitely have to think about our society, because again, early in the pandemic, we talked about how, we're all in this together. and we have to make some ethical decisions around, if one community is suffering and or one country is suffering, it will impact everyone else. Definitely with the increase in travel, that's happened. We saw how easily that happened. But in communities, in cities and towns, there will be impacts if one area is disproportionately impacted. We will have increases in all sorts of negative behaviors. And, these are things that we have to think about and put into our planning. And again, maybe these are some predictive tools that we can develop to see what will be impacted in the future.
So if I could add, first of all, maybe I'll try to interpret your question, Jude. I didn't hear it very clearly. I think Cherryl gave a really nice answer. I think we have to acknowledge that each disaster, be it pandemic, be it natural disasters, always affects the people who have the least to protect themselves or respond, and makes matters worse, in my opinion. So I think the acknowledgement that this happens at multiple scales, be it in a city where there's a poor neighborhood versus richer neighborhood, versus in a state where there are poor parts of the state, in the US versus richer part of the states, or across countries. And this is a phenomena that shows up at every scale. And I think the first step is to acknowledge this fact. And I think people sort of realize it, but we saw the best and the worst come out as a society, and where we saw folks trying to help each other during this pandemic, but we also saw vaccine nationalism, where people, institutions and organizations held back these things. So this is typically the case. But to a larger point, I think, Jude, you're making about whether these AI tools might have adverse effects and they put people out of job. If I heard this correctly, I think it's true, but it's a real problem, but it's a problem that is very hard to stall. I think it's hard to tell the world not to make progress in AI systems, right? So, but I would take somewhat positive view on this and see whether this helps. Maybe it's not. It's a view which is somewhat challenge and contentious. But I think that through this we have a real challenge. I think African countries are sitting at the cusp of what I would call age dividend, and so are other lower middle income countries, where they have amazing talent pool and youngsters. And if we can only essentially empower them with these tools, I think that they might be able to do things that the world needs. For instance, I think it is foolhardy, in fact, in my opinion, for folks who sit in countries that are well off or regions that are well off, to understand and appreciate the problems that places that are not well off have. Almost certainly the tools they make are not going to be useful, in my personal opinion, because they don't understand the problem. So here we have a very interesting challenge and an opportunity for the local folks to use the context, to use the situation to build tools that are actually useful for their community. I think this is really possible. It will require a certain amount of social movement where people come and try and train these people, but I feel that this is starting to happen slowly but surely. I hear a lot of positive stories. This is not to say that the problem is solved by any means, but I feel somewhat of an optimist in the sense that this is the time when these countries can take off if we can provide the right resources to them. They just have the right mindset right now. And the young population that these countries have are all set to make genuine contributions to the world.
Thank you so much. Do you have a follow-up question? No? Thank you. Any other question from the audience? No?
I just wanted to just add that. I mean, I really love the positivity in this question, the answer to the question, because I think we've said it. Innovation should be. I know it's an overused word, but this is a time for innovation, and this is a time that we really have to open our minds to what's possible, rather than thinking that these advancements are a detriment to society. But it has to be collective, and we have to ensure that the resources are going to the places that are needed. And this is equity. The essence of equity is really what we have to remember and keep in mind.
Thank you so much. Thank you so much, both of you, for being here today. We learn a lot from your experience and expertise. Thank you, everyone. So we will close this session, and we will be in contact for sure for some follow-up around all those questions.